Nope, I see it on yours. Yes.
Yeah. Hi, Dr. Drozek. Nice to see you.
Hi, Yashoda. I'm good to see you too.
I'm so glad that you were able to jump on. And I'm sure what was a pretty busy Monday morning for you. So I really appreciate it. And I want to thank you for being here. And I just want to let the audience know as they come on board that they can post questions for you by just putting questions in the comments section. So Dr. Drozek I is one of my respected physician mentors, I guess, a little bit, and he is a board certified general surgeon who has made this amazing transition to practicing lifestyle medicine. And I think, Dr. Drozek, you're the first like non FP, non-internist that I have on here because I do get asked a lot by different specialists if they can practice lifestyle medicine. It feels like a barrier to them, and so I'm just so glad that I was able to have you hop on here so you can give them some tips on how they can do that. So I'd like to start by asking you a little bit about your journey, about how you transitioned from being a general surgeon and now practicing almost exclusively, right, lifestyle medicine.
Mhm. Yes. Yeah. Well, it's one of those stories that I won't go into all the details because you've heard lots of stories about how lifestyle medicine changes people. But I hit my 50s. I was a practicing general surgeon, pretty busy, pretty rotten lifestyle, grabbing pizza, McDonald's, whatever I could get between cases, and on the way home, wasn't sleeping well, a lot of stress, all the lifestyle that goes with that. And I had my fridge in my office stocked with Dr. Pepper and Snickers bars.
Oh dear.
And I hit 50 and thought I ought to go see my primary care doc, like we tell everybody to, and I did. And I found out I had prediabetes and high cholesterol and high blood pressure, and I knew I was overweight, and I knew I had GERD, and was taking whatever samples I got from the drug reps for that, or the over-the-counter versions that I bought. And the doc that I saw did nothing other than pull out the prescription pad. He gave me a prescription for Janumet, which is Januvia and metformin for the diabetes, and he had a chart in there from the company that produced Janumet, saying how if I took it, it would slow down the onset of diabetes, which I was all interested in doing. I'd taken care of enough people with diabetes to know I didn't want to have that, nor the complications.
Yeah.
So I was fine with that. And he wrote me a prescription for a statin. And I thought, well, okay, that's what you do when you have high cholesterol. Said nothing about diet, nothing about exercise. Said, come back in 3 months and I'll add another pill for the blood pressure and see how you're doing. So off I went. And I knew enough to know that I probably should switch to at least diet, Mountain, or not Mountain Dew, Dr. Pepper, and get rid of the Snickers bars. So I did. And I did lose about 5 pounds on my own. And I thought, well, this Mediterranean diet's kind of popular. I think I'll try that. So I was having, low-fat yogurt for breakfast with fruit. And, I always ate a lot of fruit and vegetables, but I had a lot of cheese, lots of dairy products. And we had avoided red meat already, so I was avoiding red meat and processed meats at home, but still grabbing stuff on the road that I probably wasn't being helped by. But I thought, well, I lost 5 pounds. We should be making some progress. And when I went back to the doctor, the cholesterol was down. The statin worked. But I also was one of those people that developed the muscle cramps, one of that lucky 20%. But I didn't realize it right away. It took a while for me to figure out why my legs were aching so much. So I actually was cutting back on my exercise because it hurt to exercise. It was like I had overdone my exercise the day before and was just achy the next day, but it was that way all the time. Diabetes was progressing. And I thought, well, this is just the way it's going to be. And then I heard Dr. Esselstyn, another surgeon who transitioned into lifestyle medicine.
That's true.
And he was in Athens, Ohio, where I live, and changed my life and my direction. And I was a little skeptical at first, and then I read China study and some the Adventist health study results, and I thought, wow, this sounds for real. So I went totally plant-based, whole food diet, and got off my medicines, got well, reversed the diabetes, and the GERD went away. I lost 30 pounds, and
wow,
I thought, this is powerful.
Yeah.
And I wanted to share it with patients. Fortunately, in our community, had an organization that was running the CHIP program, the Complete Health Improvement Program. So I signed up to be a facilitator, went to training, and then went into the first class, never having been through the class. First time I went through it was first time I facilitated it. And I watched the videos the week before everybody else did, and then watched them again with them, and began to see the changes in people in the classes, and thought, this is great. This is what medicine's really about. Getting people well, not just delaying their diseases or managing their diseases. I thought this had something in it that was really exciting. So
how long ago was that, David?
Well, I had my transformation. May 2011 is when I heard Dr. Esselstyn. It was probably the following year that I got involved in CHIP. And then I went to the hospital I was working for, which at the time was a small community hospital run by a larger organization. We had a lot of latitude locally to do things out of the box. And our CEO, I presented the CHIP program to him and said, hey, this is something really great. Is there a way we can give this to our patients, our employees? And he looked at it and said, well, I can't justify paying that for people. And our patient population is pretty poor. We're in Appalachia, Ohio, Southeast Ohio. And he says, I don't know how we can bill for this. He says, but if you develop your own program, maybe we can make it work. So about that time, fortunately, Neil Barnard came to town, spoke. I got to sit by him at dinner, and I was talking to him about it. And he says, well, hey, we just made these DVDs just for people like you, so you can start doing lifestyle medicine with your patients. So I grabbed his DVDs and kind of developed my own program that has evolved over time. And I ran a couple of classes. I began talking to people individually, especially when they came in for endoscopy appointments. They did a lot of endoscopy, and most of them, we're talking about lifestyle diseases. It's the cause for why people were coming to see me.
Yeah.
So I would start to incorporate that in. I had literature that I gave people. I had this handout, talked about my own transformation, and then talked about what they could do. And the nurse, when they checked in the patient, would give that to them. And oftentimes they'd be reading it when I came in. Sometimes it was already in the trash, so I figured they weren't too interested. But a lot of people then asked, well, tell me more about this, and opened the door, and I got to share with them. And then it was fun. I'd schedule them for colonoscopies, and then I'd see them back in 6 weeks, and they'd say, I lost 4 pounds already. I'm doing it. And it was cool how many people were actually embracing this and making changes. So then I developed the classes and started to do classes. I didn't bill for them initially because I didn't feel comfortable billing. I was learning how to do them. So we did community classes with food demos, similar to CHIP, but we just kind of did our own with our own free materials, Dr. Barnard's videos and stuff that I supplemented from Dr. Greger and Full Plate Diet. And we got the same results. It was cool. It just happened. And over time, I quit doing surgery. I continued doing endoscopy, but I wanted to dedicate more time. And the long story short is the hospital system was changing, shifted around quite a bit, and I was ready to get out of surgery. And when I talked to the person who was then in charge about totally retiring from general surgery and expanding lifestyle medicine, I guess I had the silly idea that they'd be interested in it. And his comment to me from this nonprofit hospital system was, my job's to make money. And
God.
what you want to do is not going to make any money.
Wow.
So you're released from your contract. Have fun, do what you want. And fortunately,
Amazing.
I found a small independent practice that was willing to have me. The other thing I should mention is I teach half-time at Ohio University. So that once I quit doing surgery, that was my income. I was living on that because lifestyle medicine wasn't providing much and still doesn't at this point.
Right.
But I then started doing individual patients in this practice and bring up to do some classes. And then the practice got, well, this is it. I'll just throw in the towel from trying to run a practice, and I'll just do this free to the community, and I'll live on my university salary. And then the hospital that bought out our practice said, no, we had some plans for you. And in essence, they've hired me for employee health. They had tried the CHIP program in the past, had some limited success, but again, the cost for the CHIP program was a barrier. So they figured they'd just hire me and I could do my program. They wouldn't have to pay anything for CHIP. And then I'd see patients as well. So in January, I began my first round of classes with them. 3 different locations. We were running classes and we were having some great results, and we're ready to have our final session and celebratory potluck, and COVID hit. So we got canceled.
Oh dear.
But we had great results, and I still get emails from people. A lot of them were employees at the hospital. So now we're developing an employee health program that's going to try to integrate lots of things, following somewhat some of the model of Dr. Roizen in Cleveland Clinic and some of what's been done at Johns Hopkins, trying to find what works and will work best in our setting. And we're probably going to run virtual classes for our employees because they don't get charged for the class anyway. And I'm going to have some limited size classes. I've got to cut down the size of the class to account for the distancing.
Wow.
Which that's a big problem when you're billing for lifestyle medicine. When you do the classes, you got to have enough people in the class to make it worthwhile.
Right. So you were doing in-person group visits before COVID hit.
Yes.
Can you expound on that a little bit more in terms of the logistics of it? How many patients, how many weeks, what other support staff you had, were you billing insurance, that sort of thing? Yeah.
So I'm used to doing this on my own because it's always been on a shoestring and I've never had a team, but actually now I have some support from the hospital. We have some exercise specialists and dietitians that are learning to work with me on this. They're just getting involved. There's a little skepticism on part of the dietitians at this point, but I think they're interested. I think they're just concerned that people aren't going to stick with it, especially in Southeast Ohio, that they're going to want their meat and macaroni and cheese and things like that. But we'll see. I have some clinic staff, but what I do for the classes, so the clinic support staff schedules everybody. I like to get at least 10 to 15 in a class to make it viable and make it reasonable for discussion wise. The nice thing about classes versus individual patients, I found that with lifestyle medicine, the no-show rate for individual patients is pretty high. Maybe part of it's my patient population. A lot of people are on Medicaid or have no insurance. The Medicaid people have no copay, so that's not an issue, but oftentimes people living in poverty don't have reliable transportation. Plus, I make them set goals,
Yeah.
And they haven't set their goals, and they wake up in the morning and maybe it's raining, and they say, I don't want to have to go tell them that I didn't meet my goals. I'm just not going to go. I don't know. I don't know why people don't show. But the no-show rate is pretty high, which for my individual appointments, I set aside an hour. That's not sustainable financially.
Right.
To have a 20, 30% no-show rate for our appointments. But with classes, so you get 15 people and a few of them don't show, it's not as big of a hit. Plus,
Right.
the classes, the people like the social interaction. I find once you get past the first week and you filter out the people who find out what this is really about and aren't interested, pretty good attendance. And when people show up, they email to apologize, and they say, what can I do to get caught up? The classes, just the shared medical appointments just really work well. So I have a series of 8. We have food samples. So when people arrive, I have them sign in. I do a self-weight. So I don't have any other staff there. It's just me. The people come in. They weigh themselves. They fill out an intake form, which asks how they've been doing since the last time I saw them, which I scan into the record as part of the review of systems. So we check the boxes on things along that line. Then at the end of then we go through whatever the session is of the day, and then end of the class, we have a summary sheet that on the back has goals that they set.
Okay.
They set those goals. One of them is to do the recipe that they sampled at home. So the first part of the session is we go over the recipe. They're eating it, saying, hey, this is pretty good. And I show them how easy it is. And then they're supposed to do that. And they set their goals. And then I scan the goals into the chart before they go. They sign it. I sign it as a prescription to them, and that's part of the medical record. So we check that box, and then off they go. And then usually we try to do the classes every week. If we sometimes skip a week for holidays or things, but try to get the 8 classes done in no more than 10 or 11 weeks.
So do their classes only cover the diet, or are you also tackling the other pillars of lifestyle medicine?
Yeah, the whole spectrum.
Okay.
And it's all on my website, and it's there. I offer that up as a model to anybody that wants to use it. And we just migrated it to our hospital website. I can't remember the actual address for it, but the link, the old one still works. So it's www.thelifestylemedicineclinic, no spaces.
Lifestylemedicineclinic.
.us. .us, like United States.
.us. Okay, thelifestylemedicineclinic.us.
Yes, and that will get people to the new one, and it goes through each of the sessions and explains them. My first session, I start out with fiber, because I don't want to scare them off or stress them too much by saying, okay, here's what I want you to quit eating.
Right.
We approach it, use some of the full plate diet strategy. We just crowd out the unhealthy stuff. So I ask them to work at it a couple of ways. One is to fill 3/4 of their plate with food that is high in fiber and in water, and explain what that is. And I also encourage them to count their fiber and work up to 40 grams of fiber a day. And we have this eating continuum with the animal products and processed foods on the left and in the red, and encourage them to move down toward eating more plant-based on the right. I reassure them that they don't have to go completely vegan, that they don't, it's not, the further they go down the spectrum to eating healthy food, the better the results.
Right.
If they don't make much change, they shouldn't expect to get results and then blame me or the program.
Right.
It's up to their effort. But I encourage them to, they don't have to give up anything that's really near and dear to them, but maybe eat it a lot less often, less portion size, save those for special occasions, for celebrations.
Right.
So
So I think that's a big barrier for a lot of people. They're like, oh my God, I'm never ever going to have to eat a small piece of cheese in my life ever again. And it's like, no, that's not what you're saying. I think that distinction between being vegan from an ethical standpoint versus being whole food plant-based is one that I tend to, talk up a lot with my friends and family or whoever is interested in hearing about these things. Yeah.
Yeah, our second session then gets a little bit more into the meat of it, really. We talk about the blue zones.
Yeah.
And what is common about all the blue zones where these people live long and well, and they don't eat much in the way of animal products. So then we talk about that. And all of these, I give them examples. We have a recipe book. Dollar General is very popular as the primary grocery store for many people in our area. So I have a shopping list. It's not ideal, but it's at least guides them in the right direction. The things they can do from Dollar General, foods they can buy there, and recipes that they can make that are definitely healthier than the SpaghettiOs and the macaroni and cheese kind of stuff that they would be doing.
I guess the message being, it's shifting of your dollars, right? Because this is another thing we come up against where people say, well, it's all fine for you to say, but eating healthy is more expensive, and it's like, no, there are tips and tricks around this that, we're just talking about shifting your dollars. We're not necessarily, your grocery bill is probably going to be the same and sometimes maybe even less.
Yes. Meat's expensive. Yes.
Yes. Yeah. So, so in January, you started doing this with the hospital system. Are they still billing for the group visits? Is that how the reimbursement is happening? Okay.
Yeah. There's some fairly new billing codes out there that I probably should have had them available, but I'm happy to share them if anybody needs those.
That would be awesome.
Email me at David Drozek. It's DAVID. DROZEK at me.com. And you can ask, and actually you can email me through the website that I gave you too. But and I'm happy to share the coding that we use. But there's some more specific codes that have come out within the last couple of years that apply to the classes really well. The downside of those, what we were doing for the classes was using more of the standard billing codes and using like the 99, I can't remember the numbers now. I'm going to get confused.
Like 213, 212.
Yeah, the standard encounter codes and billing them for counseling time or for like a 15-minute visit. It's a 90-minute class. And I know a lot of people are doing that, but a lot of people are reluctant to do that, feeling that that's not the ideal code, especially now that there's other codes out there that we can get into problems with insurance fraud if we, bill a bunch of people as individuals, but there was no other option for a while. That was the best fit, but now there's specific codes, but the RVUs are pretty low. So that's the downside. We really got to work at lobbying to get the RVUs up where they need to be to make this worthwhile. Right,
for sure. So the new codes are specifically for group or shared medical appointments?
Yes.
I see.
Yep.
Okay, but the RVUs are less. And so again, the more patients you can get in the door, the better your reimbursement is.
Yes.
Yeah.
Exactly.
And so do you think there's a difference in terms of group involvement or people following the program if there are more of them? I mean, is there like a sort of a break point, or you think you can, even if it's 20, 30, you should get equally good results? And I know it varies on the person too, but what's your kind of general sense around that?
Well, when the classes get beyond 15, even 15 sometimes is a lot if you've got people with lots of questions.
Yeah.
That's one of the tough things is when, there's always somebody that's got a lot of questions. And I try to steer, I'll say, why don't you stay after? Because that's kind of a specific question to you that maybe not everybody everybody. But if it's something that applies to everybody, it's great. Where do you get your protein? That always comes up, and do I need to take supplements and da-da-da-da? That stuff always comes up. And that's great for general discussion. But when somebody says, well, my doctor gave me this blood pressure pill, and it's, then that's a one-on-one conversation.
Very much more specific.
Yeah. And actually, for the shared medical appointments, under the description for those codes, you have to give each individual an opportunity to talk to you individually face to face. So I get there early and I stay late, and I tell people, if you have something specific you want to talk to me about, I'll be here afterwards. Hang out, we'll talk. When the classes are smaller, we have more discussion, but when they're larger, I have to kind of clip that off a little bit and maintain it through the material for the session. Right.
So do you do these in addition to seeing them one-on-one, or are you focusing mainly on the group visits right now? Well, right now, meaning pre-COVID.
Yeah, I tried to steer away from individual patients.
Yeah.
And try to do all groups. In January, I had like 3 individual patients left that I'd been seeing for a while. Everybody else I steered into groups. People, I've tried to offer both at the same time. People generally want the individual appointment. They think they want it. And they do. They want it. They legitimately want that. But we know from the studies that in the groups, they do better. The physician enjoys it more and does better. They develop this group dynamic, and they don't see it. They come in that first class, everybody's timid. We do have it's not a binding release, but it talks about you're part of a shared medical appointment. You're going to hear information from other people that's private to them.
Right.
Please don't share it. Don't talk about anything other than generalities. Don't say, well, so-and-so that I work with has this issue when you go home, and have them sign it. I can't follow them. We can't enforce it. But it's something there that we've made them be aware of and acknowledge. And I talk about that too. I have a specific slide in our introduction and just encourage them, please don't share private information with anybody else. But once they get past that, they develop this nice camaraderie. It's a difficult thing, and they're going through it together.
Right.
And they support each other, and the discussion shifts. Instead of me giving all the answers, we try to shift it toward them giving each other answers. So somebody said, well, I can't find such and such. I can't find salt-free beans. Well, somebody else says, well, so-and-so, this, Giant Eagle has them, and you just got to go to this shelf. And, and they start to answer their own questions among themselves with the discussion, which is really nice.
Yeah.
And some nice competition among, friendly competition. Hopefully it's all friendly among each other too.
So I'm guessing you do other biometrics other than just weight before and after the 8 weeks, like the cholesterol, blood pressure, diabetes, et cetera, Do you do that as well as part of the program?
Well, what we're just getting ready to do, again, part of that was a problem because of expense, to order lipids and things out of their yearly cycle with their primary care doc. Insurance covers once a year, and I don't want to make people, again, most of my patients are resource poor. They're struggling financially, so I don't want to add bills to them. But for our hospital employees, what we're just getting ready to offer is a health risk assessment where we get blood work, calculate the BMI, get blood pressure, and have a series of questionnaires that they will do. It's going to be offered free to all the employees and their spouses. And it will give me that baseline data. We're also going to ask them to participate in the research. We have IRB research protocols approved. And that will be my data, and we're going to repeat it after they participate in the different activities. My class will just be one activity that's optional for them.
Mhm.
but I'll be able to go back. I'll have them repeat the health risk assessment after the class, so I'll get the before and after data. And we're doing things like the PHQ-4, exercise vital signs, and the lipid profile and hemoglobin A1Cs, blood pressure, BMI. Those
I think some programs are using like point of care equipment. I know Dr. Barnett's program in Rochester was doing that. Well, now they've gone virtual with their Jumpstart, but I know that when they were doing it in person, they were doing, people come in on day one, they get everything checked, and then it's kind of included. They do charge something over and above what they can bill for insurance, but between all of that, they're able to make it work, financially speaking, too.
Yeah, I was investigating that, and I was getting some pushback from our hospital people, partly because they have to ask for personnel there, and just the being able to do that in a classroom setting and make it compliant, OSHA compliant, and everything. Yeah, getting a little pushback. Yeah, but I was going that route, but right now with the employees, I'm just going to have them. They can go to any of the labs in the facility.
Right.
They get it done for free. So.
Right. So David, what about tips for like recruiting patients? So it sounds like you're mostly now concentrating on the employees of the hospital, and so that's kind of a fairly, I mean, I shouldn't say easy, but low barrier, kind of a steady stream. You're advertising. Tell me a little bit, because that's the thing. How and I think we've had this conversation before, where how do you get the patient into your door?
Well,
capture eyeballs.
The good thing in our community has been the CHIP program, and people identify what I do with the CHIP program.
Mm-hmm.
And so people who either don't want to go to CHIP or want to follow up to CHIP or something along that line, there's a good understanding in our community by a lot of the primary care docs what that is.
Okay.
So there's a handful of primary care docs that send a good number of patients to me that want to try something rather than the standard medication route.
Mm-hmm.
So the non-employee, up till now, as we just get started with the employees, up till now, I've had people coming to me who basically already wanted to do it. So that was good. My challenge now is I have this employee base where I'm suspecting the majority of the people aren't going to be interested. Mm-hmm. And we've got to figure out how to get more people interested, because the hospital is self-insured. And they spent $9 million last year. It's just a medium-sized hospital system. And they spent $9 million on diabetes care alone.
Wow.
Last year. So if I can put a dent in that, I can easily cover my salary.
Right.
And I think I can, but I've got to figure out how to convince this population that they need to come be part of my class. So the first step is this health risk assessment, where they will get on their printout, you have prediabetes, you have diabetes, you have a 80% chance of developing diabetes within the next 5 years, or heart disease, X% chance of developing a heart attack or stroke.
Right.
You want to face them with that information and then say, here's what you can do about it. Mm-hmm. Here's a class, here's silver sneakers, here's Weight Watchers, here's a list of things that are available, but my class will be up near the top. So hopefully they'll choose that. And
Right.
So I don't have to answer how to get them in. That's always.
It's a work in progress.
Yes.
Yeah. So they don't have, but financially it's not an issue, right? Because these classes are free for them.
For them, correct.
So that's not a barrier at all that way. So it really is about motivation, I guess.
Yes. Mm-hmm. And for the paying patients from the community, the classes are the good thing about the new preventive codes is there's no copay.
Okay, good.
So that's a plus. So that takes down the barrier of a copay, which maybe, and it's per class, so they might have to spend $15 to $50 per class copay the old coding way, again, for a affluent population, that's worth it to them. But
Right.
for our population, that's a significant barrier. But we were able to take that away from that as a barrier. And then individual patients for Medicaid has no copay in Ohio where I practice, but other insurances have copays, and I've had patients tell me that's been an issue for them.
Yeah. So it really sounds like the group classes have lots of pros, and and you're saying, and basically it's the one message that you're giving to 15 people at once versus repeating yourself 15 times a day.
Right.
It's a lot more efficient.
Yes.
Are you seeing any movement from ACLM or any other organizations, and to lobby for higher RVUs? Since do you have some inside knowledge about that?
Yes. A lobbyist hired by ACLM. I send in my request to lobby specifically for these codes and to add the codes cap out at 60 minutes. I do a 90-minute class, so there's no modifier or anything you can even put on to get that extra 30 minutes reimbursement. There's a 30-minute code and a 60-minute code. And, theoretically, I guess I could extend the classes to, do 12 classes and do them shorter. I used to do a lot, CHIP does 18.
Right.
I started doing my classes. I did more. I did less material, more discussion, and the classes were a little shorter. But I found that there's a decrease. You get up about 10, 12 classes, and I guess people get tired or...
Yeah.
8 seems to be the sweet spot for me, that I can, 8 people will come to 8 classes.
Right.
And then when you get beyond that, I think people just start to tail off. So that's what works for me.
Yeah. So are you guys doing these virtually now because of COVID, or have you just kind of paused it for now?
We paused it because they couldn't figure out a good way to bill for these classes virtually. But now that we're getting geared up to do them for free for the employees, we're waiting. The health risk assessment is being built. We're doing it all internally with our IT people. We're really excited about it. We got a bunch of computer geeks that we're supposed to, hopefully in the next week or two, get the trial for us to work through and see the beta version, see where the bugs are. But, those are expensive. If you go out, there's all kinds of companies. They're always there at the ACLM conferences trying to sell their product. They're expensive. To be able to do this internally, it may not have all the bells and whistles, but if it gets us the essential data and it motivates the employees to participate, I think it'll be a win-win all the way around if we can do it with less expense.
Right. I'm just going to remind our audience again, I think we have a few people on. If you guys have any questions for Dr. Drozek, please start posting it in the comments, or I'll just be the one asking all the questions. So David, I think let's say there's somebody who, a lot of physicians now are employed, they're not really in private practice so much, and they are very keen on bringing in lifestyle, whether they're primary care or they're a specialist. What are some maybe talking tips to how they can approach the people who basically hold the purse strings, right? Like, how did you manage to convince the hospital that this was a good thing for them, and how do you do that whole networking and because unfortunately, as physicians, we don't have that power at this point.
Yeah, again, for me, I think the key early on was that I was a general surgeon and the hospital wanted me. And they were willing to let me initially do about 5 to 10% of my patient volume as lifestyle medicine, because I was making money for them as a surgeon. That was worthwhile. But when I quit doing surgery, they had no interest.
Right.
But the new hospital system, because of they saw the benefit internally to save money on their self-insured plan. I think that's we've got to be creative in what we promote. As it's backward. The current system, is so backward. We make money
Yes.
when people are sick.
It's crazy.
And
Yeah.
you try to tell your employer, I'm going to make people well so they don't need to come back as often. And they quit. And
It is. It's very backward.
procedures. It's backwards. It's ethically backwards.
Yes.
So there is a perverse morality or ethic to manage disease rather than to reverse disease.
Totally.
So it doesn't make sense economically right now. And but if we move to universal care in some sense that's different, if we can flip that motivation so we actually make income and by keep people well, then I think this will make a whole lot more sense.
Yeah.
We're in this transition time. It's just you got to be creative and ask. Can I try a little bit of it?
Yeah. Yeah. Some sort of a pilot program or something like that. Do it after hours. That was kind of my, I was hoping to do that, but in my previous job, and it didn't go anywhere. But I think now there's more interest in that company, and so I was going to reach out to a couple of physicians and see if there had any any progress there. But so Blanca asked, do you know where I can review information about the preventative codes?
Yes, I can email those, and I'm sorry I didn't have them available, or I guess I can email them to you and you can post them.
Yeah, I can certainly do that. So I can just put that in our Facebook group, so we'll get those codes to them for sure.
Yeah, I'm sorry. I should have been proactive.
No, that's okay. I mean, like I said, Monday morning, it's a new week, and here I have you on. We're about 45 minutes into this. So David, did you have any other suggestions or any words of advice for the younger physicians coming on board? I mean, I know there's a lot of interest now. I think ACLM has grown to more than 4,000 members. There's a lot of physicians talking about taking the boards. Because I think that's another important part, right? Like we need to kind of know what we're talking about. And I do believe I got Dr. Barnard's DVD as well. It's just one single DVD, but that's a very low barrier way to start, where you can just, get 8 people in the community, do free classes or charge them $10, I don't know, whatever, get them in the door, and then you can just show the DVDs and then have a discussion about it, right? Like that's a very easy way to get started without putting too much pressure. Because I think as physicians, we want everything perfect and big and, almost complicated before we're willing to take that next step. But, like you said, sometimes you just start very simple, right?
Yes. Is there a way I can share my screen? Let me try that.
Yeah, of course.
I think.
So you should be able to, at the bottom, do you have a little thing that says share screen? Oh, yeah, there you are. Okay. Yep, we got your screen up.
That's my website.
Okay.
So just like others have helped me get started.
This is great.
This is free to anybody who wants to take it. It's all free material that I borrowed or begged or got from other people. So I've offered this specifically for my medical students so they can get up and running. I tell people, use this if it helps you, to give you a template, get started and go from there. So I've got my clinic tools down here, which has lots of the information, all the, let's see, there's another one. Where is it? How to use this website. It's there. And there's one. Oh, I must have it hidden. I've got it probably somewhere else. I don't want to waste the time doing it. But I've got a spot on here specifically with all the resources for other people. But you can find them, everything here. So, for example, here's the first class. My PowerPoints are they're right here. You can download them. You can use them, change them, make them your own. The goal sheet that I use, the patient information sheets that I give, the recipes, it's all right there.
Oh, wow, it's amazing.
So first, what I go in class, and then I give them homework. And as you can see, there's full plate diet. There's Dr. Barnard. There's something from Chip. So I just borrowed additional materials, so they go through that for part of their homework. That then reinforces what they do. And then if they want to even go further, there's Dr. Barnard again, Dr. Ornish here, Hans Deal down here. So I just, over here, Forks Over Knives, Chip. We just keep, it's borrowed stuff.
Mm-hmm.
So.
Are there any copyright issues with any of this? Like if somebody wants to borrow this and use it in their own practice, do they need to be reaching out to PCRM or nothing like that? Oh, wow, cool.
The people that have problems, well, I shouldn't say problems. There was one person I really liked, and I used it in my classes.
Yeah.
When I wasn't charging for them.
Yeah.
And with his permission. But when I began billing, he wanted to come up with a legal agreement that it became very burdensome. So basically, I quit using his materials and took them down. And I just used his stuff as kind of a template and made my own stuff that was enough different that it's not, it's probably not recognizable that it's from him.
Yeah. I mean, that's the thing. It's the information is the same about lifestyle medicine and whole food, plant-based. Maybe you put a little your own spin on it or your own sort of personality on it, but it's hard not to look like you plagiarized it because it's all the same.
Right.
And I know Dr. Barnard's being like super, generous. And I mean, the DVD cost me like $10 to ship it to Hawaii, and it's got all his stuff on there. And so it's easy to kind of just start with that. And then maybe, like you said, create your own and put your own stamp on these things. So it does take some time, I guess, to get started. And then the other thing, maybe talk to some of the primary care docs in your town or, go to the hospital committee and let them know that you're starting this up and that you would welcome their patients, that you're not really planning to steal them. You're just borrowing them for a while to improve their health. And then you'll be sending them back to their, to their primary care docs for like their routine maintenance, right? That's another option.
Yes, that's one of the things I'm very careful about is I don't want to steal anybody's patients. I tell everybody I'm not a primary care doctor and I generally don't prescribe medications or change medications. I might suggest turmeric or ginger for certain things, but generally, if somebody, and I tell them right up first session, if you're taking insulin, if you're taking blood pressure medicine, you may need this adjusted within a week or two.
Right.
Be in touch with your primary care doc. And oftentimes with individual patients, I'll call a primary care doc and they'll say, hey, their blood pressure is really low and they're hypotensive. And if you like, I can decrease their medicine right now while they're here, or you can, and, their office will take care of it right away. But I don't want to do that and take patients away from somebody else.
For sure.
The other thing that's been really helpful, I think, in recruiting patients is community events.
Mm-hmm.
Athletic center or community center has a series of speakers in, and we did our own in our office. We had one at New Year's, start the new year well, and I use the blue zones as kind of a thing. And then is it February that's Heart Month? You can have a heart healthy presentation. I mean, you can do things free to the public and then make them aware of, if you want more information, come see me. We can go deeper with this.
Right, like October Breast Cancer Month or something on there going on.
Right.
Yeah, that's another good point to make as well. So after the 8 weeks are over, what are you seeing happening with these patients? Are many of them managing to sustain the changes? Do they come back for a refresher classes if they've kind of fallen off the wagon?
It's a mix.
Yeah.
Like anything. What we hope to do with the hospital I'm working for is really get a good ongoing support network set up. In our community where I'm at now, we have a CHIP alumni course, our group that meets on Fridays. They have a potluck, and they've been gracious and allowed me to refer my patients, even though they haven't gone through CHIP. They've allowed them to come and join their group. So some of them do that and continue with kind of that support. So
Nice.
things like that.
Yeah. Well, I mean, this is a trudge. This is not a marathon. I mean, this is hard. We're trying to change culture around food, and I mean, people are very familiar with. Yeah, we know that smoking's not good for us. Yeah, we know we should exercise more. Yeah, our sleep should be better. But food is such a personal thing, and I think the highest barriers come up there, especially because we're kind of a very meat-centric culture here. Like, I grew up in India, we were not meat centric. There's still a high percentage of people who are quote unquote vegetarian. Of course, they do fair amount of dairy and whatnot, and deep fried stuff is very common. So this is not going to be an easy thing, but I think the nice thing to see is more and more physicians are coming on board. And I think also patients are getting tired of, the 15th drug that makes them feel like crap.
Yes.
So, yeah, I mean, I think our moment is, and especially now with COVID and all the information and data there is out there, that people with chronic illnesses and obesity are the ones who are dying or ending up in the hospital and much sicker with the virus. Seems to be another, it's kind of like, this is our time to kind of do that education piece.
Yeah, another thing you can do is bring some other supporting programs to town. Walk with the doc.
Oh yeah. Are you part of that too?
Well, peripherally, the organization that sponsors CHIP helped bring it to town, and I've gone on some walks and got the shirt. But I mean, that's something you could do yourself to bring awareness to what you're doing in the community. And
yes, yeah, lots of different avenues here.
Yes.
You do have to make time for it. You do have to have the passion for it, though, and you have to be willing to persist even in the face of what appears like failure, like what happened in your case, right? When the hospital said, well, if you can't bring us the big bucks, it didn't make you give up and go back to just doing the endoscopies or whatever, right? Like you said, this was your passion. This is something you really believed in doing. Yeah. Well, David, do you have any other last minute pieces of advice for any of the physicians who are watching now or might be watching this later?
Just that it's an exciting time as we see what is developing. There's going to be lots of changes. I'm hoping that this telemedicine option gets expanded here. We didn't quite get it figured out enough that our clinic people were willing to give me the green light to start doing telemedicine, lifestyle medicine with telemedicine. They weren't sure on how to code that appropriately, but I think our patients like telemedicine. This is ideal for telemedicine.
Yes.
So if we can keep moving forward, and I know Ohio just recently passed, like within the last week or so, an extension of telemedicine payments for Medicare patients, at least, or Medicaid.
Nice.
And I haven't had a chance to figure out what that means yet to us. But I don't think we're going to go backwards. So if we can make sure that we get lifestyle medicine reimbursed by telemedicine, that makes a lot of sense.
For sure. Yeah, I mean, it's the perfect marriage. You don't really need to be examining these patients, and everything that you can do in person, you can do on all these different platforms now. You can do cooking demonstrations if that's part of your classes. You can do, I mean, the whole group dynamic. And yeah, like you said, like I said, I've been doing telemedicine, not lifestyle medicine related, just urgent care type of stuff. And invariably, people love it. They love the convenience. They don't want to go back. They want to be at home in their pajamas when they're sick, talking to a doctor. Sometimes we're having to twist their arm to go in. I'm like, yeah, no, you're having chest pain. I'm not trying to deal with that on this platform. You need to go into the ER and get troponins checked or whatever. So it's kind of been, because Remember the days when people would go into the ER for a stubbed toe,
Yeah.
Now the ERs are half empty, going, where are our patients? So things have definitely changed. And, in a way that's almost like a silver lining, I think, is medicine is not going to look like what it used to even 6 months ago. And I think the ones who are nimble and can kind of change according to whatever the current circumstances are, they're the ones who are going to be successful. And I really think lifestyle medicine's time has come. I really, really do believe that. I think there's a lot more awareness of how much disease reversal and prevention can happen with just doing some, fairly simple, straightforward things. But I think the more of us that we keep talking it up, the louder our voices can be. So none of us should stop talking about it, I guess.
Yeah, if we can get the right people in the right positions who will be essentially successful. We need to get rich, but we do need to make a living and pay off our medical school debts. And
right.
Something's gotta go to make this worthwhile for everybody.
Right. Yeah, like I was telling you before, Padmaja Patel, who's in Midland, Texas, her sort of inroad, because she's managed to create a pretty decent sized lifestyle medicine clinic setup, was one of her C-suite, I don't know if it was a CEO or CFO or somebody, was having health problems and basically, changed her diet and everything. And so she became a believer. And so she was supporting Dr. Patel all the way through. So maybe arrange for, 4 free classes for the C-suite at your hospital.
Yes, great idea.
Right?
Yes.
And for doctors, I mean, we're terrible. Like you said, we eat horrible, we stress crazy, we don't sleep, and we're like the worst examples of lifestyle medicine. So that's another group maybe to kind of say, hey, I'll do a 4-week if you guys are interested, and kind of educate them. So then once they change and they become convinced, that they're starting to send you patients as well. So
yep.
Lots of different ways to approach this. Thank you so much, David. I really, really appreciate you spending your time with us this morning.
I've enjoyed it. Thank you.
Yeah. And hey, I'll reach out to you later, but I think I can help you with printing up that website of yours. We've talked about this before. So
okay.
I'd be happy to give you some time to kind of make it just, a little bit.
Yeah.
I have some ideas. So
use the help. Yes.
And I have the time, so we'll work on it.
Okay, great. Thank you so much.
Thank you, David. Thank you so much for being with us. Really appreciate it. And good luck with your future endeavors. We'll stay in touch. Okay. Bye.
Bye.